Okay, I think we're ready to go. We're going to start with chapter 41. Well, first of all, welcome to OBGYN 1. And in these two classes, both fall and spring semester, we're going to be looking at um, both the gynecological systems and the obstetric portion of sonography. Both of these are part of a modality called OBGYN. So first, I think it'd be important to start off with the gynecological side. So we will look at the anatomy and physiology of the menstrual cycle, um, how our organs work, like uterus, ovaries. So that's where we're going to start off. Okay, so there's a lot of objectives for this course, but the highlighted ones are the ones I really want to focus on. So I definitely want to focus on this, describe the pelvic organs and functions, discuss the physiology of the menstrual cycle and the hormonal changes, describe the development of what an ovum is, and define the function of the corpus luteum. Those are going to be our main objectives in this chapter. So here we're looking at the female pelvic organs. If you cut a person in half and we're looking inside sagittally. So as you can see, and you should have know this stuff from anatomy physiology, but we'll go over it again. The anterior portion, this is the bladder right here, and then the uterus kind of lays on top of the bladder, and then behind it is the rectum. So this is kind of the orientation of the female pelvis right here. This is the fallopian tube and ovary here. This is just looking at the bladder. We do scan bladders quite a bit, female and male. And so you'll learn more about that in abdomen. But to just look at it here, when the bladder is empty, this is the uterus right here, and it kind of lays on top of the bladder. So, and it's kind of interesting, as the bladder fills up, it pushes the uterus down into the posterior portion of the pelvic cavity. So with the uterus and the reproductive system, our first thing we're going to look at is the vagina. And the vagina is a muscular tube that connects from the external genitalia to the uterus. So it usually extends upward and backward from the vulva, and it lies in the half in the pelvic floor, and the lower half lies in the perineum here. It's usually around 9 centimeters, which is interesting, that it's that long. And it usually goes upward and backward about a 90-degree angle. Our uterus is our main thing we're going to be looking at the next couple of chapters here. Very important organ, reproductive organ. And this is what it looks like if in a coronal view. So it's a hollow pear-shaped organ. It's divided into the fundus, which is this upper portion. That's the thickest portion, widest portion. The body, which is this portion right here. And then the cervix, which is this portion, the lower portion right there. It's usually anti-flexed and anti-verted, which means it's kind of laying on top of the bladder. So let's see here if this is, let's go back. So on this one, what I mean by anti-verted is it kind of lays on top, so it kind of tilts forward. However, there is a variant, which we'll talk about later, where it leans towards the rectum, and that's called a retroverted uterus or a tilted uterus, which a lot of people have tilted uteruses. It's not totally uncommon. Most of the time they are antiverted though. In a reproductive patient, the uterus usually measures around 6 to 8 centimeters in length, 3 to 5 centimeters in AP diameter, which is anterior to posterior diameter, and around 3 to 5 in transverse diameter. So I really want you to know this right here. I also want you to know that the uterus consists of 3 parts. You're going to be tested on that: the fundus, which is the upper portion, the body, and the cervix. Know that the fundus is the widest portion. The body lies between the fundus and the cervix. The body is the largest portion, while the fundus is higher up, but the widest portion. So you can see how it kind of extends and gets wider like a triangle as it goes superior into the body. I also want you to know these sizes. So this is when a patient or a person hasn't gone through puberty yet, a woman or a girl, they're going to have a pretty small uterus. It's going to be 1 to 3 centimeters, which is pretty tiny. As a girl goes into menarche or starts her period, basically the uterus also grows and gets about 6 to 8 centimeters, 3 to 5 width. Every time you have a baby, it stretches out a little bit more and increases in size by 1 to 2 centimeters. So usually like a multiparity, which means multiple pregnancies or have been pregnant, it can get like 8 to 10 centimeters, what I usually see if they've had babies before. Postmenopausally, it's interesting though, because it decreases in size and goes back to 3.5 to 5.5 centimeters. And I wonder why that would be the case, because wouldn't you think that it would just increasingly grow as a person ages, but that's not necessarily the case. What makes the increase is the hormones. And so with postmenopausal, we're losing a lot of hormones, estrogen, progesterone. And so the uterus shrinks. So I'm sure everybody knows a little bit about a cervix. The cervix is the lower portion, very important portion of the uterus, and it has a lot of functions. The internal orifice is the part that connects to the rest of the uterus. The external orifice is the part that connects to the vagina. That's pretty easy to note. The cervix keeps the baby inside when you're pregnant, and it shouldn't dilate until you go into labor. The cervix is what, when you get a pap smear and they're looking for cells, they're looking right here, making sure there's no cervical cancer. Cervical cancer is one of the most common kinds of reproductive cancer, but it's lower portion there. Layers of the uterus, huge. This is so important. And I test my students on this a lot, even as you get into clinicals. So here we go. So the perimetrium, also known as the serosa, is the outer layer. So it's this outer membrane. The myometrium right here, this thick portion, that's the muscular portion of the uterus. That's the part that contracts during labor. The endometrium, this is the part that sheds every month. It's the inner mucous membrane. It's also where a baby would implant. The endometrium itself consists of 2 layers. The 2 layers are the functional layer. Functional layer means the part that sheds every month, and the basal layer, which is the part that regenerates every month. The interesting about the endometrium, and something that a lot of people find interesting, and I definitely do too, is that it's cyclically changes every month with the menstrual period, with the menstrual cycle. So it starts out as day one, the first day of a menstrual period, it'll shed and become very thin. And as the hormones, as a um, woman ovulates, it increasingly gets larger and thicker until the last day before you start your period again. And there's multiple reasons, and we'll continue to talk about that. But what I want you to know for that right now is that the endometrium changes dynamically in response to cyclic hormonal flux of ovulation. And it always looks different depending on the part of the cycle you are. So if I scan someone, I'm pretty sure I know what part of her cycle is she's in if she's not on birth control. So there's a lot of uterine ligaments here. And I don't want you to get too caught up in these, but this one's important. The little ovarian ligament, this keeps the ovaries close to the uterus. Another very important ligament is the broad ligament, which is this long bat-looking area here. And that kind of keeps everything in place. If you ever wonder how everything stays in place, it's because of these ligaments that are all in our pelvic cavity. The position of uterus, we kind of talked about this a little bit. A normal position, this again is that sagittal woman that is cut in half and we're looking into her. This is the bladder and the uterus lays on top. That's a normal position, rectum behind. If it's way anteverted, it's going to lay even closer to the bladder. If it's retroverted, it's going to lay closer to the rectum. And if it's retroflexed, it's going to also tilt that way. So a lot of the times you'll get someone that says, yeah, I have a tilted uterus. And what they're talking about is both a retroverted uterus and a retroflexed uterus. And it's going to be important for you guys to note this when you're scanning a patient. And I'll show you how to do that throughout the semester. I want you to know the different terms for how a uterus could lay, anteversion being the most common position. Dextroversion, dextro means right, means kind of tilted to the right. Levoversion means left. I remember left, levo, tilted to the left. Retroversion means tilted posteriorly towards the rectum. So retroversion, rectum. And then retroflexion means that the fundus and body are bent backwards. So the difference is retroverted, the whole uterus is tilted back towards the rectum. With retroflexed, it's just like the fundus that is tilted back. You usually just don't see these independently of each other. However, you usually see them together. So they're both tilted back towards the rectum and also retroflexed. Fallopian tubes. What do fallopian tubes do? Well, if you ever wonder how an egg, when a patient ovulates, and an egg is released from the ovary, it has to get to the uterus and get to the endometrial canal. So, well, basically sperm meets it in the fallopian tube, and then, conception happens, and then the little zygote goes all the way down, back to the endometrium, basically. But the fimbriae here, these little hair-like things, they grab the ovum or the egg, and they help it to start moving down to meet the sperm. It's really amazing, actually. So you need to know these 4 portions of the fallopian tube. So the fimbriae here are the hair-like projections. The infundibulum is the big funnel-shaped lateral tube. The ampulla is the widest portion of the tube, and this is where fertilization usually takes place. The isthmus is like the hardest part and lies just lateral to the uterus, and the interstitial portion is right by the uterine wall, so connected to there. These are 12 centimeters. and they get their blood supply from the ovarian arteries. The ovaries. We know about these a little bit, but we're going to learn so much about them. You're going to know, have so much knowledge on the ovaries by the time you're done with this semester in December. So the ovaries, they're almond shaped. Almond shaped, that's important. Almond shaped. They're usually only 3 centimeters. Now, if you look at that, that's pretty small, huh? But they make such a huge difference in our bodies. It's insane. They usually lie posterior to the uterus at the level of the cornua. These are the fallopian tubes, ovaries, ovarian ligament. That's how they hang it on there. Now, sometimes ovarian ligaments stretch and the ovaries aren't exactly in the place that you want them to be. Sometimes they can be posterior to the uterus or way out in the pelvic cavity, but most of the time in a normal patient, they're going to be pretty close to the sides. So these little guys are very, very, very important because they produce so many hormones for us in our life. So they produce estrogen, which is from these little follicles right here, very important. And they produce progesterone, which is from the corpus luteum. Now the corpus luteum is what we call the portion of the Graafian follicle. So let's say this one is the one that's going to grow and become the Graafian follicle. So that's going to be the winner for this month. And then you ovulate and it gets big and then it kind of crumbles up a little bit like this and becomes a Graafian follicle. And then the second portion of the menstrual cycle from 14 to 28, which is the second portion, like the secretory phase is what we call it. It becomes the corpus luteum. And it looks kind of like this on the ovary. And this corpus luteum, it produces progesterone. And the reason that we want it to produce progesterone is if you're pregnant, you want the uterine muscles to relax so it does not expel the zygote or embryo. And progesterone helps to relax the uterine muscles. Isn't that crazy? Now there's a lot of vascular flow in this area. And what I want you to know is there's some ovarian arteries here, and those actually, feed the ovaries. Makes sense. There's also from the internal iliac arteries, there's uterine arteries, and that feeds the uterus. I think that's all we're going to do with that right now. All right, so now we're going to talk a little bit about the menstrual cycle. If you're a woman and you probably know about a menstrual cycle, you probably experience it every month, but a lot of people don't know exactly what is happening that is causing it. So that's what the physiology that we're going to learn about. So usually around 11 to 13 years is when the onset of menstrual cycle occurs, and it ends around 50. The average menstrual cycle is 28 days. And day 1 is considered the first day of menstrual bleeding. So that's going to be where you count. So there's menstruation, which is day 1 to 4, if you're lucky. And then the proliferative phase, which I like to include both of these in the proliferative phase. But if you're being technical, menstruation is its own phase. So from day 1 to 4, a patient is menstruating. Then once the patient gets done, proliferative phase occurs from day 5 to 14. But if asked, I would say day 1 to 14. And this corresponds to the follicular cycle of the ovarian, or follicular phase of the ovarian cycle, which is occurring in the ovary. So estrogen level increases as ovarian follicles develop. If you know or have looked into any of those apps, they say this is a great time to get things done. This is when you feel your best because you have extra estrogen, you're feeling good about yourself. Um, it's just a good time. Like you feel like in control, you're pretty stable, like your hormones aren't crazy. And as the estrogen increases, it causes a thickened endometrium. Then ovulation occurs on day 14. If, again, if you're very, very regular. Then the next phase is the secretory phase, and that's day 15 to 28. So that's the second part of the cycle. And this corresponds to the luteal phase of the ovarian cycle. So know these two, that they correspond together. Ruptured follicle becomes the corpus luteum, which produces what? It produces progesterone. Then around like right before your menstrual cycle, like a couple days before, your progesterone just like plummets, which can cause premenstrual syndrome and irritability and trouble sleeping and um, food cravings, all the fun stuff. And that's why you feel like that. It's because your progesterone decreases so fast. Here is a wonderful picture of both of the cycles together. And it's amazing that both the uterus and the ovary, they work so good together. They both have their phases and they both do what they are meant to do, which their lot in life is to become pregnant, basically. That's what the ovary and the uterus are meant to do. And so every month they give it a good shot. And so in the follicular phase, corresponds with the proliferative phase, and the endometrium continues to grow like it should so that it can support an embryo if needed. And then the follicular phase, a follicle is growing so that it can be the one that is released and the egg can be released. And then in the luteal phase, it becomes a corpus luteum and produces progesterone so that an embryo can stay in there without being expelled from like a uterine contraction. So it just really is amazing. These are the hormone levels. And you can see estradiol rises up really good right there. So that's why you feel so good about that time. And then as ovulation, then there's a dip, and progesterone makes you feel pretty good. But then see how they both dip around this time. That's why we struggle. Well, that's why PMS exists right there. Follicular development and ovulation. I really like this. Did you know that your grandmother carried part of you inside her womb? But how? Well, a female fetus is born with all her eggs she will ever have in her lifetime. So when your grandma was carrying your mother in her womb, you were a tiny egg in your mother's ovaries. The three of you have been connected for a very long time. And I think that is really sweet. So the ovulation normally occurs mid-cycle around day 14. You need to know that is like our big day. It is speculated that the ovum releases alternates between the two ovaries, which I can say that I'm pretty just, being so able to scan people or scan myself. I'm pretty sure that does happen. So they kind of alternate, they share like one time it's the right ovary, then it's the left ovary, and then the right ovary and the left ovary. And as I've watched myself, that seems to be the case. So that's pretty interesting that they kind of alternate. The process of ovulation is regulated by the hypothalamus in the brain. So sorry, my dog is being crazy. Is regulated by the hypothalamus within the brain. When a girl reaches puberty, the hypothalamus begins the pulsatile release of gonadotropin releasing hormones. And this stimulates the anterior pituitary gland to secrete varying levels of gonadotropins, which are FSH. FSH is follicle stimulating hormone that does exactly what it says. It stimulates follicles. And the luteinizing hormone, which has a major surge, whoop, and helps a patient to ovulate on day 14. You can get these little ovulation strips if you're wanting to get pregnant, in kind of like a pregnancy test, and it tests the luteinizing hormone. And as you get closer to ovulation, you'll get like 2 lines. And so it helps a person know when they need to have intercourse so they can potentially get pregnant. These drawings are a lot better than my little red drawings that I've been doing. So this is day 1. There's a little follicle and then it gets bigger. It's bigger ovulation. This looks kind of gruesome, you know, but that's probably why it hurts sometimes. It releases the egg and then it turns into this shrinking little thing, which honestly, this is what it kind of looks like in black and white on the ovary, a corpus luteum. And then as the body realizes that it's not pregnant, it decreases and decreases, and then everything drops and you shed that lining again and it starts all over the next time. So the secretion of FSH by the anterior pituitary gland causes the ovarian follicles to develop in the first half of the menstrual cycle. So FSH is very important in the first part. This is called the follicular phase, day 1 through 14. Only 1 follicle makes it to maturity each month unless you have twins. But the mature follicle is known as the Graafian follicle. This is what I was talking about with the luteinizing hormone. The level will definitely increase rapidly 24 to 36 hours before ovulation. And they have ovulation predictor tests, which give you a happy face if you're about to ovulate. And this is called the LH surge. During the luteal phase, which is the portion of the ovarian cycle that is in day 15 to 28, the corpus, which makes sense, luteal, corpus luteum. That's how I remember. There's always a way I can kind of remember everything. It begins to secrete progesterone 9 to 11 days after ovulation. The corpus luteum degenerates, causing progesterone levels to decline and cause us to not feel good. As the progesterone level declines, menstruation occurs and the cycle begins again. But if conception occurs, HCG, which is the pregnancy hormone, is produced by the zygote or embryo, and the corpus luteum persists for 3 months. So the embryo or zygote says, hey, I'm here. Don't just excrete me out, and produces HCG, human chorionic gonadotropin, I believe. And it's the corpus luteum says, okay, I'll keep producing this progesterone for 3 months, so until the placenta takes over, so I can help you out. Endometrial changes. So this is interesting, the endometrial changes here. So it kind of looks very thin, and the menstrual, oh, this is thick. Okay, they're going to start with thick first. Okay, so thick right before menstrual, then look how thin it gets after you shed, and then it becomes the proliferative phase or the 3-line sign, and then it increasingly gets bigger and bigger and bigger until day 28. These correlate. So the menstrual phase lasts approximately 1 to 5 days. The proliferative phase will last until luteinization of the Graafian follicle. which is around ovulation, so till day 14. And then the secretory phase lasts from 15 to 28. The sonographic appearance of the endometrium changes dramatically among the 3 phases of the endometrial cycle. So it just is crazy how fast it can change in 28 days. Okay, so this is what it looks like on ultrasound. So this is what your life is going to consist of in the next 2 years, looking in gray and white. So this little line right here, this is a transvaginal ultrasound of the uterus. This line right here, this is the endometrium. This is a very, very thin endometrium. So this is probably after a patient has menstruated around day 4 or 5. Our next phase is the proliferative phase. And it's kind of hard to see in this, but this is what it looks like right here. And we call this the 3-line sign because you can kind of see there's 3 lines, and the 3-line sign correlates with the proliferative phase. Then around day 14, or sorry, day 15 to 28, look how thick that gets within a very short amount of time, from day 1 to like day 15. Isn't that crazy how much it grows? So the endometrium will thicken to an average of 4 to 8 millimeters in the proliferative phase. This will call 3-line sign. Right before ovulation, it's going to be 6 to 8, 10 millimeters. So you need to know this. So around 10 millimeters at ovulation. After ovulation, 7 to 14 is what you're going to get with the secretory phase. So write that stuff down. So it can get up to almost 1.5 centimeters. If it's greater than 1.5 centimeters, it's too thick. You can also have abnormal menstrual cycles. And these are going to be some of your medical terminology that I want you to know. Menorrhagia means heavy or long periods. Oligomenorrhea means they're not having very good periods, so they're abnormally short or light. It's associated with PCOS. Polymenorrhea means you're having more than normal cycles around 21 days. Dysmenorrhea means painful periods, and amenorrhea means absence. So A is absence, dys is pain, poly is more, oligo is less, and menorrhagia is heavy and painful. Sometimes you can get adnexal fluid, especially during ovulation. That's a totally normal physiological thing. But sometimes you can get more than normal. So you will see some fluid in the rectouterine pouch. That's where or the posterior cul-de-sac, that's where you see it the most. And that's between the rectum and the uterus. And that usually occurs during ovulation. If you have a ruptured cyst or have a lot of pain, it wouldn't be unlikely to have fluid on in the adnexa that the cyst is ruptured. That's it.